My name is Professor Norbert Skokauskas, and it's a great pleasure and honor to introduce Professor Helen Herrman from Australia. Today, she is going to speak about the best ways to prevent depression. I think most of the people in the audience know Professor Helen Herrman, and she does not require any introduction because she is one of the most famous persons in the area of mental health internationally. But let me share with you a few points. So Professor Helen Herrman is the former president of the World Psychiatric Association. She is also an immediate past president of the International Association of Women's Mental Health and the Pacific Rim College of Psychiatrists. Professor Helen Herrman is also the director of the World Health Organization Collaborating Center in Mental Health, Melbourne. She has a special interest in community mental health care, mental health promotion, and have published widely on these and related topics. Professor Herrman has helped implement research programs for mental health marginalized groups, including homeless people, prisoners, and young women and men living in out-of-home care. I think we are very lucky to have Professor Helen Herrman today, and I truly believe you will enjoy this lecture, and this lecture will be an inspiration for your future work, future projects, and future collaborations. Thank you. Please enjoy the rest of the conference.
I beg your pardon. Thank you very much for the introduction from my good colleague, Professor Norbert Skokauskas, and my thanks to the organizers, to Dr. Christina Hoven and all the colleagues in Guyana, as well as the colleagues from New York and other parts of the US and the region and the world. It's a very important conference that we're sharing, and I'll just share my screen so that I can begin to address this topic. But it's a real pleasure to be part of this conference, the Guyana Well-Being Conference, and an honor to be here as part of the program. So as Norbert mentioned, my topic is the best ways to prevent depression. And several of you here have been part of the thinking about this topic, as a number of us were working together on developing a LANCET Commission report on the LANCET WPA Commission report on depression. So I'll begin by considering the scope of global mental health, and an earlier LANCET Commission on Mental Health and Sustainable Development published 3 years ago. And then the topic of preventing depression and how we need to tackle this at several levels, at the societal level, in terms of community development and primary health care. And then I'll talk for a moment about the role of mental health professionals and partners, including the people with lived experience of mental ill health and their families, a topic that we talked about yesterday in the conference as well. So global mental health. The agenda has been expanded. There have been a lot of attention to reducing what's been named the treatment gap, that there certainly is a large treatment gap, that people around the world have relatively very little access to treatments for mental ill health, and we have many effective treatments nowadays. This is not equal either, because access is much more limited in low and middle income countries, but it's still limited in high income countries. It's said that perhaps only 1 in 3 people in the high income countries receive quality treatment for a mental disorder. So there has been a number of gains in that area in the last 10 or 20 years, particularly with scaling up treatments through sharing tasks from more experienced and skilled mental health professionals to community workers who are supervised and trained by mental health workers, and peer support and other developments. But this process needs much higher level of investment than it now has, and it will take a very long time to be effective in reducing this gap in treatment need. And we also need to catch up with the public health approach and expand to considering more fully the promotion of mental health through other sectors of society, through schools and workplaces, family supports, and other areas. And to think further about reducing the burden of mental disorders and substance use disorders as well as part of that, by addressing what's been termed the prevention gap as well as the quality gap. So the prevention gap is our topic today, and the quality gap is, even though people around the world have access to some treatments, only a few of them are evidence-based. And as I said, we have treatments that are evidence-based, but it's their availability and accessibility that's in question. And making sure that we extend the scope of treatment to include social care. This is well provided often in primary health care or collaborative care, and we can consider those topics as well. So let's turn to the determinants of mental ill health. These are very similar to the determinants of health in general. Poverty, particularly relative poverty, relative social disadvantage. Gender inequality, the position of women in societies is a particular concern. The lack of autonomy and the violence to which they are exposed at high levels in a number of communities, in most countries of the world. Social exclusion related to discrimination and to of various types. And along with these, major physical illness, that physical and mental illness are accompaniments of each other, either causes or consequences. And this is a factor particularly in older people. The social cycles of social disadvantage that influence these social determinants were defined very clearly 25 years ago in the publication World Mental Health from the Harvard University, led by Professor Leon Eisenberg and Professor Arthur Kleinman. And they talked about the interaction between health and behavior, and particularly the toxic effects of poverty, violence, discrimination, whether it be gender, racial discrimination, or other forms that are found particularly in neighborhoods, in poor settings, or in poor rural settings. And these result in high risks for mental ill health, which in turn puts barriers to health and livelihood. And this is, in more recent terms, a similar concept of syndemics has been very well described. So in emergencies such as refugee settings, where people are on the, millions of people, even before the current pandemic, were on the move as a result of conflict or climate-related emergencies, or for economic reasons, or whether people are living in informal settlements or slums or in rural poverty, mental health is is poor in these settings. There are many risks, as we've described, and it's a challenge to provide interventions to improve mental health. However, the Commission on Global Mental Health and Sustainable Development came to several conclusions that show the way forward. First, that there are cost-effective solutions to mental health care, and that puts us on a par with physical health, because there are similar barriers to intervention to improve general health, but there is much higher investment and much higher success in improving general health than in improving mental health throughout the world. And the second consideration is that mental health can be improved through interventions beyond the health sector. So we can work in family settings, with schools and workplaces, as mentioned, and through urban planning and in prisons and social justice settings. But the converse of this is that without action on mental health, the Sustainable Development Goals can't be met. In that, good mental health and good education, gender equity, low levels of poverty and climate action are all positively associated. And similarly, poor mental health is linked with poor achievement in these other areas. So this gives us an argument for and a positive cycle for the intervention and attention to improving mental health. And mental health's been reframed in three principles to reframing. The first one is that we take a staged approach to understanding and responding to mental health problems. And this is compared with the yes-no or the binary approach of current classification. So if we say, does this person have depression or not, sometimes it's not very helpful to say yes or no, but to say this person is at risk of having depression, this person has symptoms of depression, or this next person fulfills the diagnostic criteria according to the classification being used. But each of those situations might benefit from some action. I'm going to show you a diagram. I don't want you to worry about the detail, but the idea is that staging, at the top, we have mental well-being with very few coloured dots. The coloured dots are symptoms or distress or signs of depression or of other forms of mental distress, including anxiety and fatigue and lack of energy. So the more that as we go down the vertical axis, we reach the stage of non-specific mental distress, where greater awareness and understanding can promote self-help. People can seek others to discuss their situation. They can find information on the internet or in other ways. They can visit their doctor or the health station and discuss what help is available to them. Then as the symptoms grow in intensity or number, early treatment is recommended. And as we go down to the state of specific mental syndromes, there is more specific treatment available. Now, as compared with many other diseases, the non-communicable diseases, the onset of mental ill health is typically in young people, particularly those in the decade from 15 to 24 years. And 75% of people with lifetime psychiatric disorder will experience its onset before this age. And if we bear in mind that young women and men are almost a quarter of the world's population today, and that 90% live in low and middle income countries, the early intervention in young people is a very important way of reducing the burden of illness and preventing disability and later illness for those people. But early intervention is also important later in life for people with the onset of dementia or other disorders of later age, including substance use disorders. The second principle is to understand that in depression and other mental disorders, that the social and biological determinants of mental health problems interact in different ways and with a range of factors across the life course. I'm going to show you one more rather detailed diagram, again, just to get the general idea. This is a diagram of the protective and risk factors in the early life course. So from the left-hand side to the right, we can see the different stages of life from preconception to adolescence and youth. And on the vertical axis is mental health, with poor mental health at the bottom. And you can see at each life stage, there are factors that can contribute to poor mental health, and as well as sometimes the inverse of those, contributing to the promotion of mental health. If we think about healthy parents, the stimulation mothers can provide their children and their sensitive responsiveness, the lack of violence and adequate nutrition in the household, secure caregiving and positive parenting for the older children, and life skills training in schools so that emotional and social understanding is developed in young women and men, and the support from their peer groups and engagement in civic activity, including community development that we'll come to later. So the third principle is that mental health is a fundamental human right for everybody, especially those who are at risk of poor mental health or those whose mental health is already impaired. So those are the three key principles for reframing mental health. If we consider, and they help us to consider the prevention of depression as one of the most common mental disorders worldwide and a leading cause of disability in the world. A staged approach, the interaction of social and biological determinants, and the fact that mental health is a human right. And this is the young girl again in the refugee camp, a child on the move as a child in danger. So I think this helps us to understand that while we need evidence-based approaches, there are also some things like war or living in a refugee camp that we know are not good for mental health. The World Health Organization has taken these considerations into account and extended its mental health action plan to 2030. This was achieved this year in the World Health Assembly. And the third of the three objectives of the plan is to implement strategies for promotion and prevention. And the strategies that, and the targets for that third objective are, first of all, that 80% of countries will have at least 2 functioning multi-sectoral mental health promotion and prevention programs, that the rate of suicide will be reduced by 1/3. This has been increased. There was a more modest objective, a more modest target in earlier versions of this plan. And that 80% of countries will have a system in place for mental health and psychosocial preparedness for emergencies or disasters. And of course, since this was, or as this is being developed, we've had one of the greatest global emergencies with the COVID-19 pandemic. Considering the topic of prevention, I realize that most people are, or many people may be familiar with this half circle that was published in 1994 by the National Academies of, or National Academy of Medicine in the USA. And the authors were Mrazek and Haggerty. And this introduced, or this put into a very accessible form where we have the idea of prevention as one of the strategies that improves mental health. So that can be universal, selective, or indicated. And I'll come back to some definitions for that. And that complements treatment and maintenance or recovery. There's been some updating of this diagram, and the same National Academies has produced this report 2 years ago on fostering healthy mental, emotional, and behavioural development in children and youth as a national agenda. And of course, the same principles apply across the age group, but the National Academy and others believe there should be special emphasis on children and youth, first of all, because these are the periods of onset of mental ill health, but also because there are many effective ways to intervene. So we have promotion achieves a high visibility in this diagram on the left-hand side. Prevention is still there, and promotion and prevention are really sometimes achieved through very similar actions. The promotion is conceptually concerned with improving health, whereas prevention is preventing ill health, and they're not exactly the same thing. So health, as with mental health, as with physical health, it can be seen in the absence of, is more than the absence of ill health. And then we have treatment and maintenance on the other side. And the influences on mental, emotional, and behavioural health, as it's described in these reports, comes from complex neurobiological processes in the brain. So within the person, there are these complex neurobiological processes that interact with the physical and social environment And we go right back to conception and before conception with the parents, right through adolescence and across generations. Now, one more diagram, just to, because I think it's such a beautiful diagram in itself, but partly to comment on the question that's often asked: how can we prevent depression if we don't know the brain changes that cause it? Well, this is a diagram that shows the areas of endeavor in trying to work out what is the cause of depression or what is the cause of any other mental disorder in neurobiological terms. And it's a bit like health in general. We don't have a very firm idea necessarily of what causes heart attacks, but we also know how to prevent them. But there is a lot of work being conducted in the nervous system and the microbiome, the endocrine system and the immune system. But what we are clear about is that these all interact with the individual factors, the life circumstances and experiences, the family and the community, as shown in the spirals. And these are the areas we can also intervene. So, preventing depression, there is as I mentioned, this forthcoming LANCET WPA Commission on Depression. And in this, the Commission lays out the idea that we need to work at several levels, just as in preventing heart disease, that there are a whole of society strategies to reduce adversities early in life and across the life course. And this is analogous to the idea that we've come a long way in reducing the burden of heart disease in many countries in the world. And that's been achieved through public health measures that complement the advances in clinical health, clinical treatments. So diet and exercise and reduction of smoking in the case of heart disease, and we'll come to the strategies that are required to reduce depression that are analogous to those. That interventions are also needed in settings like neighborhoods, schools, and as well as at the individual and family level. And these focus on current life habits and risk factors. And again, I'll come back with some examples. But the more efficient prevention of depression is likely to have powerful impacts on countries achieving the Sustainable Development Goals, as well as the health of individuals and families, in that depression is associated with the development of physical ill health as well. So I mentioned the universal, selective and indicated interventions, that these can be used at different levels within an ecological framework, which I'll show you in a moment. So universal interventions are those that can be applied for an entire population rather than specific groups. So if we do something like poverty alleviation, or if we're working in schools, a universal intervention within a school might be to improve the school climate and the way that, for instance, teachers and students interact, or the way that we try to reduce bullying through changing behavioral strategies in schools. Then selective interventions are those that apply to people individually or in groups at higher than average risk. For instance, groups of people who have been bereaved, or people who are living in refugee settings, or people who have a family history, for instance, of mental ill health. And then indicated interventions are those for individuals showing signs of subthreshold depression. So if you think back to that blue staging diagram, it's those with a few signs of perhaps they're worried, unable to sleep, have little interest or feel sad, that these but don't yet satisfy a diagnosis of depression. And all of these interventions need to be adapted with local experts and communities. So we have evidence about what works in various places, but in all of these situations, these need to be endorsed by the local community, designed by them in terms of their local application, and evaluated by them as well. So here's a diagrammatic of representation of those ideas about preventing depression and considering this across the life cycle. So vertically, we have the different levels, the so-called ecological levels of society at the top, different types of settings in the middle, and the individual and families at the bottom. So if we think of the whole of society interventions in that top box, this is addressing the structural determinants of health, such as gender equity, improving autonomy for women, providing them with educating girls, and ensuring that they have an opportunity for a livelihood, and poverty alleviation schemes, including cash transfers or fairer distribution of income, with the universal basic income has been trialled in many places. Families, schools and workplaces, neighbourhoods, and health and social services are different settings where the at-risk groups can be identified. For instance, in neighbourhoods, interventions for loneliness or for older people, or for recreation and arts and sports for younger people. And interventions for individuals and families across the life cycle, whether these be psychological, psychosocial, for those with risk factors or subthreshold symptoms, as I've mentioned. So those last interventions, the so-called proximal or closer to the person interventions that are designed for prevention of depression, adapted versions of psychological treatments for depression have been delivered in schools, general medical settings, in pregnancy care, and also we've used, or people have used the new digital environment to assist or to provide these. And these can be either universal, selective, or indicated in nature. And overall, there are small but important effects. So these can be very meaningful, but working out the cost effectiveness requires a lot of advocacy, because the effects may be discovered over time and not necessarily through the health sector. They may be apparent in educational settings or as well. And then the structural determinants across the life cycle. So things I've mentioned like poverty and income and gender inequity, and the historic marginalisation of, say, of Indigenous populations and displacement of peoples. So these influence those risk factors that individuals face as well. And one example of an effective structural intervention where the University of North Carolina worked with a local university in Malawi to evaluate this program where relatively small but meaningful amounts of income were given to the very poor families. The aim was, and was achieved, to reduce poverty and hunger and improve the attendance of children at school. It reached hundreds of thousands of households, and there was measurement of reduced depressive symptoms in young women and young men. And it seemed that for young girls at least, this was mediated by better social support they received in their families as well as at school. And this work links up with best practices at as defined by the Disease Control Priorities report that was published in 2016, which said that the best practices for reducing mental disorders in general, including depression, to restrict the means of suicide, which is another very important initiative that we've heard about from Dr. Lakshmi and others in this conference already, but particularly, for instance, restricting access to suicides in to pesticides in several world regions. So this joins the other structural changes that can be made. Reducing the availability of alcohol in communities, particularly driven by community awareness groups, is a powerful change in a community. At the community level, the life skills training in schools to increase social and emotional competencies. And at the healthcare level, there's the self-care for those at the early stage of mental ill health in particular, but also at later stages to augment, hopefully, further treatment. And the availability of mental health care and treatment through primary care and through community outreach, including through the task sharing. So moving to social policies and community development, in other words, how do we develop some of these ideas and interventions in individual countries? Well, most countries around the world have signed up to human rights declarations and covenants on the rights of women and rights of children and the rights of people living with disability. But these and many others are not enough to change attitudes and cultural practices in most places. And laws that some countries may move to pass laws and train police forces, for instance, about gender-based violence or other topics. But once again, these are often incompletely used and not meaningful for the population. So change needs to come from the bottom up as well as be facilitated by changes in policies and laws. And these two young women are good examples of what can be achieved by the community approaches. They've achieved changes at local level as well as community level. At least not necessarily they've achieved themselves, of course, but they've inspired others to take action. So Greta Thunberg on climate action and Malala Yousafzai for education for young women. And this idea of community action is very strong in various parts of the world, including Latin America and Chile. These are the women portrayed in street art in Chile because of their formidable presence in community action. So community development's a process. Community members take action on things that are important to them. They're supported by outside expertise if they request it, and develop science-based policy and action. And the important ingredient is empowering community members and enabling communities to be stronger to meet mental health needs. Community knowledge and wisdom is valued, and the process is led by community members and guided by human rights and self-determination and collective action principles. The core ingredient is participation, and this requires self-confidence. And this in turn is vital for and an important part of good mental health. So there's a real virtuous cycle between participation, self-confidence, and good mental health. Good mental health enables participation and is promoted by participation. And this in turn is required to tackle social and health goals, to empower people to work with their community groups and consider how to reduce availability to alcohol if that's a priority for the population, to consider maternal and child health and violence at home and in the streets. A well-known program, Communities That Care, that originated in the Northwest USA and is now active in hundreds of cities around the world, has reduced delinquency and violence in the street, violence in many cities, and the need for reduce the need for resources in justice. And this type of work is very important and influential in emergency settings and informal settlements, including making sure that vulnerable people, women and children, receive access to assistance. UN Women endorses this, and there's a Respect Women is a joint initiative of WHO and UN Women. And this provides women as a strategy for preventing violence against women that begins with empowering the women themselves. So I'm aware we started a little late, so I might just move a little faster through this. But if we consider depression in the perinatal period, this can be an important way to tackle this is to protect women from human rights abuses. So those social determinants of mental ill health, insecurity and poverty, gender discrimination, women who don't have any choice, and preventing violence at home. Up to 1/3 of women in the world, in most countries, report violence, intimate partner violence at home. And sadly, this is more prevalent in pregnancy than in many other periods of life. And then at the more individual level, there's the importance of early identification of risk factors and poor mental health. So when women come to antenatal services or are seen in communities, the health workers need to be empowered and understand how to manage that situation and listen to the women and know how in the local circumstances to provide safety as well as assistance. And then there's the capacity to prevent depression in primary care. And this, there are participatory approaches, the collaboration with women and their families in terms of self-help groups in villages led by peer facilitators, as well as community workers in primary and maternal care, that these are trained and supported by practitioners. And the Thinking Healthy program in India and Pakistan has reduced the prevalence of depression in women in poor rural areas. So we come back to the fact that we're faced as mental health professionals. If we turn to the situation, how can we act? What can be done in the face of these circumstances? Well, if we think about the communities, we need to partner with the communities to help strengthen the capacity of communities to respond to mental health needs. So the professionals can contribute to mental health awareness and support, and endorse the importance of working in education and family welfare settings, helping urban planners to make decisions, and making use of the digital world in ways that are safe and effective. And of course, this is not the expertise, this is not what mental health workers were trained to do, but it's this partnership idea to work together with these other groups in ways that make sense locally and at different levels, either at government or in neighbourhood groups. And mental health professionals need to be trained and ready to work in this way, to engage with communities, to meet with mental health planning and support groups in schools, to train midwives and empower them to recognise and provide assistance, provide treatment for women with mental health problems. Need to be able to work in teams and to think in systems terms. If we change one thing, how does it affect life in this family and life in the neighbourhood? So if we link midwives and nurses to training and support with mental health professionals, they can manage most problems themselves, but they need continuing access and support from the trainers. Digital programs can help here as well. So mental health professionals trained as trainers and trained in skills for community-oriented practice. And this is turning the pyramid of mental health care on its head, but it's a way to consider the culture of the mental health professions and how they can be most helpful, in that most of the care that people receive and perhaps need to receive is through self-help in the community. Community workers play an important role and can be supported through primary health care. But the mental health professionals are indispensable. They're at the peak of the pyramid, and they, as well as the work that they need to do with people who need a specialised level of care, they are critical for training and supporting leaders in primary health care, who can in turn support their own colleagues in primary health care and community workers, and encourage the work of community self-help. So I'll finish by noting that preventing depression is everyone's business. We need to convince the rest of the people that that this is their business, whether in whatever sector they work, whether it be business or government or education. COVID-19 is amplifying the disadvantages and social determinants of depression and other forms of poor mental health, particularly the violence and the gender-based and racial discrimination that we see played out in various settings, including the ones mentioned. This requires work across all of those sectors, supported by community development and integrated with primary and health care. And it's if we can engage others in governments and communities with these concepts and approaches and our own enthusiasm, it's possible that we can follow the example of heart health and have dramatic reductions in prevalence and suffering from depression in the decades to come. Thank you.